Okay. Okay, so today we have to start from asthma and COPD. And as we all know what asthma is, what is it? It is chronic reversible airway inflammation characterized by periodic attack of wheezing, dyspnea, chest tightness, and coughing. So what we need to know about the diagnosis that before the age of 6, we do not diagnose asthma with any specific test. It's like the doctors do it with a clinical diagnosis and with sign and symptoms. We do not do pulmonary function tests, spirometry before age 6. So if they ask you that at what age we are going to start spirometry, it is after age 6. Okay. Because it's a difficult test and children below age 6, they do not know how to do it. So the results can be a little up and down. So that's why we do not rely on that. Then peak flow meters are useful in office and at home for monitoring. So to monitor asthma at home, we can give the patient the peak flow meters and we can to monitor their symptoms, and we can tell them, okay, you can monitor it at home. And if at any point the symptoms are getting worse, what they're going to do, they're going to come back. Then after that, we have COPD. Okay, in COPD, what it is irreversible. Asthma is a reversible, but COPD is irreversible, and asthma has a history of family history, allergies. COPD is in mostly above 60 years with a history of smoking or any other genetic cause. It can emphysema, like it can be due to any other underlying cause. So just to know the differentiating points, what we have to, just a second, the people just joining in, so sorry. Okay, so the COPD, the age is 6 decades, which is above 60 years, mostly old age people, they present with it. They have a history of, most of them have a history of smoking. It is of 2 types, the chronic bronchitis and emphysema. Then it is the irreversible inflammation or obstruction of the airways. It is slowly, and with passage of time, it is going to worsen. Along with that, there won't be any history of allergy, but the patient will give us a history of any smoking or might have a work-related issues. He might be some firefighter, he might be working in some mines, or he might be deficient of alpha-1 antitrypsin deficiency since childhood. So that is for emphysema. But for other, the air pollution, cigarette smoking, occupational, these are more common in chronic bronchitis. Then the symptoms are going to be chronic cough, sputum, and dyspnea. After that, the diffusion capacity, it is also going to be decreased. And with spirometry, there won't be any improvement. In asthma, with spirometry, there will be an improvement. But in COPD, there will not be any improvement after we give bronchodilators in the spirometry test, because it is an irreversible condition. So there won't be any improvement. But if we do same methacholine challenge test in asthma, so there will be improvement in the symptoms. Similarly, the chest X-ray can be normal, but as the disease progresses, we can see increased bronchial markings, chronic hyperinflammation, bullae, all of these can be present. Or in the initial stages, it can be just normal. So chest X-ray is not the diagnostic test. How will we manage it? If a patient is coming to us with COPD, okay, first of all, we have to, he's a smoker. Similarly, like yesterday, just counsel him to quit smoking. Okay, then we will start the patient on salbutamol. This is Ventolin. If the patient is not improving, then mostly we do the triple regime. What is the triple regime? It is SABA plus tiotropium and salmeterol. Okay, so there's a difference in the management of COPD and asthma in the second step after that. So you should know that, okay, because they do ask you. So here after Ventolin, we are giving SABA, tiotropium, and salmeterol. If the symptoms are still not resolving, okay, it is moderate, it has turned into moderate, then along with it, we can add inhaled or oral steroids, but they are not given for a long time and we have to monitor them. Okay, and after some time, we have to taper them off. In severe cases, what is it that we have to, along with this therapy, we are monitoring the patient, and we will then start the patient on oxygen, at home oxygen. Okay, that is very important. They might give you a question and they might ask you that what are the, it can be a CDM question, that what are the mortality reducing factors in a patient with COPD. So what are the mortality reducing? A smoking cessation, then home oxygen, and along with that, pneumococcal vaccination, annual, and influenza vaccination. So these are the mortality, 3 things. They will reduce the mortality in a patient with COPD. But always remember, we do not start a home oxygen, even if the oxygen level of the patient is like below 50, 55, if the patient is smoking. We always have to start home oxygen if he's not smoking. He has quit smoking, then. So when do we start home oxygen? First, we have to counsel him to stop smoking. Then when he stops smoking, after that, we can start home oxygen therapy. Similarly, for asthma, it is mostly seen in children, and with age, 50% of the cases, they outgrow it. The children do get better. And the most common trigger is allergy or a family history of asthma. Along with that, it is a reversible cause, so it can be treated. It will, family history. Then what are the environmental triggers? Now, it can be seasonal or all day, mostly all the year long. During the pollen or dust time, what will the patient present with? He will may present in the ICU, in the emergency department with exacerbated symptoms. So for that, we will have to treat him accordingly. The triggers are pollen, dust, animal fur, cold air, exercise. He might have a history of upper respiratory tract infection a week or 2 ago, and now his asthma symptoms have worsened. Cigarette smoking, use of beta blockers, and aspirin. Along with that, wheezing is the hallmark symptom. Then dyspnea, chest tightness, prolonged expiration, cough, which is worse in the cold, at night and in the early AM. So they might only, in children, the mother might just bring in the child and she might say that, okay, the child just has a cough and he or she coughs the whole night. In the day, the child is fine, but at nighttime, they are just coughing. So this is one of the signs of asthma. In asthma, the nighttime cough is more prominent. So then we have to investigate further and look into it. Similarly, in this, the diffusion capacity is going to be normal. And when we do the spirometry test or methylcholine challenge test, there will be marked improvement. The symptoms will improve. On chest X-ray, it will be normal. Very, very rarely we will find like episodic hyperinflammation or hyperinflammation during, but the chest X-ray is not the diagnostic test for both of these. Okay, they will have attacks and they might be presenting with severe disease, and the chest X-ray might be just normal. So how do we start the management for asthma? First of all, for the parents or the person himself, we are going to educate them. We are going to tell them you have to avoid all the triggers. Avoid if you're going, it's the pollen season, or if there's some dust, wear mask, avoid all these things, take proper cautions. Then for rescue medications, we will start them on Ventolin. If the patient comes and he says that, okay, I've been taking Ventolin and my symptoms are not being controlled. So what are the signs of poorly controlled asthma? He is on Ventolin, but still he's doing all the conservative management, but still his symptoms are not improving. How will we know that? He's using beta-2 agonist more than 4 times a week. Okay. Then asthma-related absence from work. He says that, or the mother says that the child is being absent from the school a lot of time. I have to not send him to school because of his symptoms. Then exercise. When he exercises, his symptoms get worse. And nighttime symptoms, more than 1 time per week. You should know all these 4. Okay, this either it can be a CDM question or it can be an MCQ question. So just know these four signs on your fingertips. When you know these four signs, then you will be easily able to understand the, okay, is it a like a poorly controlled asthma? Do we have to move on to the next step, or we have to just stay over here? So if he is presenting with any of these signs, he's taking Ventolin more than 4 times a week, his symptoms are not getting better, then we start them on low dose inhaled corticosteroids. Okay, so then we are going to start them on corticosteroids. In COPD, we never start them on corticosteroids. But in asthma, the second step is corticosteroids. If with corticosteroids, they are not getting better, then we move on to LABA or leukotriene receptor modifiers. Okay, so first Ventolin, then inhaled corticosteroids. After that, we have to add, it's not that when we're going to start LABA or LRTA, we're going to stop steroids. No, along with that, we're going to add this. Then similarly, the same. If it's still getting worse, we increase the dose. Okay. And at last, this is a very rare step, like immunotherapy, not done routinely and not needed much. Then what will we do? Similarly, annual pneumococcal vaccination and influenza vaccination to prevent them from any like pneumonia or upper respiratory tract infection, because those are what? The risk factors. If the person experiences these, he will have an attack of asthma. This is all the management we are doing. Remember, right now we are talking about family medicine. So this is the management we are doing in the office setting. Okay, but if the person comes with an attack in the emergency department, the treatment is going to change. And we are going to discuss that in emergency. I'm not going to discuss both of them together here because it can confuse you. So first, you should know if a patient is coming in an office setting and he is presenting with you, his oxygen level is normal. What will we do? We'll start them on this and monitor him and regular follow-up. Always remember, if they are coming in the office setting and you notice that their oxygen level is down, their respiratory rate is very high, what will we do? Urgent referral to the ED. Okay, because it means they need urgent, they might need intubation at that time. So urgently, we have to refer them. We won't just give them salbutamol, or we won't just increase the dose of their medication and send them home that, no, you're going to be fine. At that point, they will give you, and they will also give you the values. Okay, the oxygen level is this, the respiratory rate is this. So if you see that the oxygen level is anywhere below 90, even 91, below 90, the respiratory rate is above 30, it means the patient is going in hypoxemia and we have to treat him emergently. So emergently, we have to urgently send him to the emergency department. And always remember the DDs. For all these family medicine cases, you should know the DD. What is the DD over here? For wheezing, allergies, anaphylaxis, asthma, reactive airway disease, GERD, infections, obstructive sleep apnea, COPD, congestive heart failure, foreign body, malignancy, cystic fibrosis, and vocal cord dysfunction. And always when we are prescribing a patient on salbutamol, one of the side effects of salbutamol is hypokalemia. So we have to monitor the patient on that also. If he is taking salbutamol and he comes up to us and says that, doctor, I'm feeling lethargic, or I have some muscle aches for the past few weeks, we do have to check his electrolyte levels. Okay, so the signs of hypokalemia are lethargy, irritability, paresthesia, myalgia, weakness, palpitations, nausea, vomiting, and polyuria. Okay, so the next topic is, yes, the next topic is BPH. Again, it is an important topic. And what is it? That BPH is the hyperplasia of the stroma and epithelium in the periurethral transition zone. Know the DDs. If the patient is presenting with symptoms of BPH, what are the DDs? Prostate cancer, urethral obstruction, bladder neck obstruction, urogenic bladder, overactive bladder, cystitis, prostatitis. And one diagnostic test, we are going in patient of BPH, they might just present with urgency. They might just present with any urinary incontinence. They might just present with retention. They just come to you and they say, doctor, I'm not able to pee for the past, since morning or since last night. So what is that? That is retention. They might just present with some dribbling. So it all depends upon the symptom they present with and how we have to treat them. And remember, whenever a patient is presenting with, if they are giving you a question and in the question they're giving the symptoms, few symptoms, and they're asking, if they're not giving you the complete history or physical examination, they're asking you what is the next step. The next step is taking a complete history and physical examination. Okay, if they're asking you what is the next investigation, BPH is always diagnosed on DRE. So it is the physical examination which helps us diagnose BPH. We are not doing any invasive test for it. After the complete history, maybe the patient is using some drugs, some medications like anticholinergics, which can be a cause of the retention. He might have some recent surgery, any trauma, anything could be there. So we have to ask about all these things. Then we move to the physical examination. And on physical examination, DRE. Always remember, never forget. DRE. In DRE, what we are going to check? Size, symmetry, nodularity, and texture of the prostate. How will we find it in BPH? It is going to be symmetrically enlarged, smooth, and rubbery in BPH. In case of cancer, it is going to be not symmetrically, unevenly enlarged. It is going to be firm, hard in cancer, prostate cancer. Similarly, in prostatitis, it will be very tender. Okay, so these are the differentiating points on DRE examination, how we are going to know whether it is a BPH, it is a cancer, or a prostatitis. Then when the patient is presenting, what will we do? Okay, first let's do the symptoms. The symptoms of BPH are, we have obstructive symptoms, irritative symptoms, and late complications. So in obstructive, he might present with some hesitancy, diminution in size, and force of urinary stream interruption, urinary retention, post-void dribbling, overflow incontinence, and noxuria. Or he might present with some urgency, frequency, noxuria, urge incontinence, dysuria, same. Hydronephrosis, these are the late complications which can be there due to prolonged BPH. So you can just learn it or keep in mind, like frequency, urgency, noxuria, fun, wise. Then weak stream, incontinence, straining, and erectile dysfunction. So these are the major symptoms of BPH. Okay, then if the patient is presenting on physical examination, we did the DRE, we said, okay, he is having BPH, but along with that, we have to do some urine test also. So we have to do urine analysis to exclude any UTI, and PSA is not done. It is a very rarely and a very high false positive result. So it is not done. Never write PSA for any, if they're asking for anything about prostate, if the option is PSA, that is not correct. Okay. Then how will we manage the patient? It all depends upon the severity of the disease. If the patient is the symptoms are severe, then we have to refer him to the urologist. But if they are not severe, he's just like he has some frequency, urgency, not that much, or he's coming with nighttime symptoms. First of all, we have to educate the patient. Always conservative management. We will tell him, okay, avoid caffeine, avoid alcohol, do some fluid restriction. Then avoid monitoring of certain medication, avoid or monitor. So if he's on certain medications, which could be a cause like antihistamines, diuretic, antidepressants, we'll tell him either we reduce the dose or we'll monitor them. And if we can switch the medication, why not? We'll switch it, but all depending upon the patient's condition. We will tell him about some exercises like pelvic floor or Kegel exercises, bladder retraining. We'll schedule voiding, educate him about all the conservative management. Then we will move on to the pharmacological treatment. What is pharmacological treatment? We can either give either of these depending upon the whatever we need to do. Like alpha receptor antagonists, like trazocin, tamsulosin, doxorubicin, they relax the smooth muscle around the prostate and bladder neck. So we can use these. We can use 5-alpha reductase inhibitor finasteride in patient with enlarged prostate, and anti-muscarinic and beta-3 agonist. Okay, so mainly we use these two, the tamsulosin and finasteride. These are more commonly used. Then if the patient is also presenting that he says that I have some erectile dysfunction, for that, we are going to give him sildenafil, phosphodiesterase inhibitor. If he has nighttime symptoms, we can recommend him desmopressin for noxuria. Okay, if the medical management fails, the conservative management fails, then we will move on to the surgery. And what will we do? We will refer him to the urologist for the surgery. And what is it? TURP and TUIP. If failed medical therapy, intractable urinary retention, BPH leading to renal insufficiency. So these are the indications when we are going to do TURP. Also, we should know the red flags. Like if the patient is presenting with any of this, what we do have to do? We have to refer them. We are not going to treat them in the office setting. We just give them the conservative management, the medical management, and just refer them. So severe symptoms or pain. Men less than 45 years old, abnormality on DRE, hematuria, elevated PSA, incontinence, neurologic disease known to impact lower urinary tract symptoms. Then urinary retention, post-void residual urine volume more than 250 or a palpable bladder. Also remember, if the patient is coming to the office with a urinary retention, he says that I'm not able to pass urine. So what we have, first thing we have to do is catheterize the patient. Okay, we have to relieve his symptoms. So we are going to catheterize him. And for that, similarly, nothing over here, all these things are not done in the office settings. We do not have the facilities in the office settings. So for that, we have to refer him. We'll send him to the emergency department for catheterization. Then we have bronchitis. What is bronchitis? It is a clinical diagnosis. Okay, and most commonly it is viral. 80% of the cases of bronchitis are viral. So it is going to resolve on itself. Patient is going to present with symptoms like cough, flu-like symptoms, and what we will tell, he might have a sputum with the mucus with the cough. So mostly clinical diagnosis, tell him about the conservative management and send home. However, if the symptoms are getting worse, always educate them to come back or go to the emergency department, call 911. Okay, acute infection of the tracheobronchial tree causing inflammation leading to bronchial edema and mucus formation. Fifth most common in family medicine, upper respiratory tract infection, mostly caused viral rhinovirus, corona, adenovirus. Acute bronchitis is a clinical diagnosis. See, we just don't jump onto the test. If the patient is presenting with symptoms, we see that these are viral symptoms, clinical diagnosis. We don't have to be a right unnecessary test. We have to be a careful doctor. Then what is the primary prevention? Frequent hand washing, smoking cessation, and avoid irritant exposure. Educate the patient. Symptoms relief, fluid, rest, humidity, along with that analgesics, and if needed, we can give him antitussives for all that mucus and for the cough. Bronchodilators may offer improvement of symptoms. We can give the patient salbutamol also. Okay, so this is it. Like it's not something not a very important topic. Then DDs of bronchitis are upper respiratory tract infection, asthma, acute exacerbation of chronic bronchitis, sinusitis, pneumonia, bronchiolitis, pertussis, environmental or occupational exposure, postnasal drip, GERD, congestive heart failure, cancer, aspiration syndromes, cystic fibrosis, and foreign body. And remember, you should always know the diseases or the conditions which have clinical diagnosis. Always make a list of it, write that, okay, this, they have clinical diagnosis. We can diagnose them on clinically. We don't need to go on for some specific test. The tests are only going to be done if after the clinical diagnosis, if after the initial management, the symptoms are still worsening, then we move to the next stage. Okay, otherwise it is a clinical diagnosis. Then chest pain, very important. Mostly it is more important for the emergency medicine. Okay, so first we're gonna do, okay, so this is the DD. What is the DD for the chest pain? Acute MI, chest wall pain, GERD, panic attack, pericarditis, pneumonia, heart failure, pulmonary embolism, acute thoracic aortic. If you know the DDs and they are giving you the symptoms, you will easily know that, okay, this is the symptom for this. This is the investigation we have to do, or this is the management. So you should know the differentiating symptoms. Otherwise, all of these will present with chest pain. But how will we differentiate them? In acute MI, the pain radiates to both arms. Third heart sound is present on auscultation and hypotension. And always remember, if a patient is presenting with chest pain, what are the first tests we are doing? We are doing ECG, cardiac biomarkers, chest X-ray. Okay, if they are giving you a scenario and they're asking you what are the tests we have to do ECG, chest X-ray, and cardiac biomarkers. Then other tests depends upon the condition, and how we are going to proceed, it depends upon the condition. Similarly, if the patient has some chondrochondritis or chest wall pain, it is going to be a reproducible pain on palpation. GERD, they will have a history of retrosternal pain, acid regurgitation, sour or bitter taste in the mouth. 1 week trial of high dose PPI relieves the symptoms. For panic and disorder, what in the past 4 weeks, one question that have you had an anxiety attack before? Then for pericarditis, it is the classic triad of pleuritic chest pain, pericardial friction rub, and ECG changes. And the patient might have a history. He might come in with chest pain and give you a history that 1 week ago, I had an infection, any infection, it can be any viral infection, and it just subsided, and now I am having this chest pain. So what is this? It is most probably pericarditis. For pneumonia, agophony, dullness to percussion, fever, and clinical impression. Pneumonia is again a clinical diagnosis. Heart failure, pulmonary edema on chest radiography, clinical impression or judgment, history of heart failure, and history of acute MI. For pulmonary embolism, the patient might come in and say that, doctor, I'm having a very bad in the ED. They present with a chest pain and give you a history that I traveled a week ago, and since then I am having very bad pain in my leg, one of my legs, and it is swollen. And today morning I had a sudden attack of chest pain. I'm not able to breathe. He might present with respiratory distress. So he might have some symptoms of DVT leading to pulmonary embolism. He might have some recent surgery. He might be in the hospital and immobilized. So all of these are the risk factors. It might be a woman presenting on long-term use of OCPs. So it can be any one of these. Then acute thoracic aortic dissection, acute chest or back pain, and a pulse differential in the upper extremities. Okay, so what are the risk factors for coronary artery disease? They are major and minor. Risk factors are smoking, diabetes, hypertension, hyperlipidemia, family history of coronary artery disease in the first degree relatives, male less than 55 and a female less than 65. Untreated obstructive sleep apnea, chronic kidney disease. Similarly, for minor are obesity, sedentary lifestyle, and age. These are modifiable. We can change them. If he's obese, we can tell him to lose weight. Sedentary lifestyle, get up and exercise, do more work, physical. Age, of course, age is not modifiable, but these two we can. If he's smoking is also, he can quit smoking. So there are some modifiable and some non-modifiable risk factors. Red flags, severe pain more than 20 minutes, new onset pain at rest, severe shortness of breath, loss of consciousness, hypotension, tachycardia, bradycardia, cyanosis. He's presenting with any of these red flags, emergency, immediate referral. In elderly and in diabetics, they may have some atypical findings. Okay, so in elderly, how will they present? They can present with dizziness, back pain, lightheadedness, or weakness in the absence of chest pain. They might just present and they say, I'm feeling a little dizzy, I have some back pain. So in the absence of chest pain with MI, and that it might be an MI attack, and we shouldn't take that lightly. Okay. Similarly, in diabetics, they may just present with dyspnea, syncope, and fatigue. Then, if a patient is presenting to the emergency, to the office setting, and he says that, doctor, I feel that I have a chest, like I'm having an MI. So if the patient is feeling that he's having an MI and the symptoms are also according to it, then we have to send him. We have to treat it as an MI. Okay. So ruling out coronary artery disease in primary care, how will we rule it out? Out of these points, if 3 to 5 are positive, then we will treat it as an MI and send him to the emergency department. Age and sex, female more than 65 and male more than 55, 1 point. Known clinical vascular disease, coronary artery disease, occlusive vascular disease, or cerebrovascular disease, 1 point. Pain worse during exercise, 1 point. Pain not reproducible by palpation, 1 point. When is pain reproducible by palpation? It is in costochondritis. So if we are pressing and the pain is reproducible, most probably it is some muscular pain, because in MI it doesn't do that. Then patient assumes pain is of cardiac origin. We always have to listen to the patient. We have to go with his willpower also. So 1 point. So if it is 3 to 5, then it is a positive, and it is most probably a coronary artery disease, and we have to treat accordingly. If negative, less than 2 or 2, then okay, we'll treat it in the office setting, and we can send him home with some medications and tell him that go to emergency if any of these symptoms worsen. Investigation, ECG, chest X-ray, and refer to ED if suspect serious etiology. Management of common causes of chest pain. Now, if the patient has angina or ischemic heart disease, what will we give him? First of all, we'll give him nitroglycerin sublingual 3 times. It can be form of the spray or sublingual, anyways. We have to give him 3 times with 5 minutes apart. Still, he is not getting better, send to the ED. Okay, they are telling us in every scenario that we have to send the patient to the ED if the symptoms are getting worse, if the symptoms, we suspect anything dangerous, because this is very important. Okay. Always when a question comes, first read what is the setting. Is it an office setting or is it an emergency department? In emergency department, then okay, fine. We are safe. Okay, we'll treat according to the emergency. But if it's office, then we have to check, okay, now he's in the office, or the patient is maybe on, he called you, he's on a phone call and he's telling us all these symptoms. So how we have to deal with it. Then in case of MI, what are we going to immediately give? Aspirin, stat, then low molecular weight heparin, morphine, oxygen. So if the patient is presenting in the office with an MI attack, what we do? We give him aspirin and we immediately with the nitroglycerin, and we call the emergency services, and they'll come and they'll take him. Okay, we can't give him morphine and low molecular weight heparin. Everything won't be started in the office setting. Just aspirin, stat, chewed, urgent referral. If they're giving you 2 options, then these 2 would be the best. But if they're giving you 4, 5 options, then you can write everything. So it depends upon the number of options they have given you to write. Then reperfusion therapy with fibrinolytics, for example, tissue plasminogen activator, reteplase, tenecteplase, or streptokinase, if within 12 hours, ideally, or time from the first medical contact to percutaneous intervention, if less than 30 minutes. These are not done in the office setting. This is the emergency setting. Then beta blockers. Start beta blockers. It's a long-term management. Beta blockers we are going to give to the patients. And if we are suspecting any endocarditis, we'll start the patient on antibiotics. Similarly, for GERD, if we are suspecting GERD, the patient comes in with the chest pain and he says that, okay, doctor, I have a history of regurgitation, metallic taste in the mouth, and now for the past few hours or since yesterday, I have this chest pain. So what will we do? Educate the patient and start him on a trial of PPI. For GERD, first of all, the investigation is a short trial of PPI. Whenever he's presenting with these symptoms, a trial of PPI, if the symptoms improve, then we will continue PPIs. But if the symptoms are not improving, then we have to move on to the next step. If costochondritis, any muscular pain, give him NSAIDs. Okay. Then the next is common cold, also known as acute rhinitis. It is also most commonly a viral infection, upper respiratory tract infection, most commonly caused by rhinovirus. And mostly it is seen in the winter season. In the winter season, the patient 6 to 12 year or adults, they will present with it. What are the symptoms? Symptoms might be nasal congestion, sneezing, sore throat, conjunctivitis, watery eyes, cough, These are all the viral symptoms. Okay, if the patient has a bacterial, mostly they don't present with cough. Then journal malaise, headache, myalgias, mild fever. Signs we will check for any nasal or oropharyngeal mucosa. It will be erythematous. Enlarged lymph nodes, normal chest examination. Complications are bacterial infection, secondary bacterial infection. That is otitis media, sinusitis, bronchitis, and pneumonia. So these are the complications. After 1 or 2 weeks, the patient may present he can present with pneumonia, any pain in the ear. So we have to check that also. Did he have any other history of any upper respiratory tract infection, which has exacerbated his symptoms? Then the management. First is patient education. Symptoms peak at 1 to 3 days and usually subside within 1 week. Cough may persist for days to weeks after other symptoms disappear. No antibiotic indicated because of viral etiology. Okay, so just symptomatic treatment, reassure the patient and give him saline washes and frequent hand washes. Along with that, tell him to disinfect everything, drink plenty of water. So it's going to be fine. And yearly influenza vaccination. If he has it every year, just tell him to get the influenza vaccination. Mostly it is influenza vaccination is recommended here. That every person's people, they do get it in every season, like twice a year. So it is recommended for everyone. Then for same symptomatic relief, hydration, rest, gargling, steam, nasal irrigation, analgesics and antipyretics. And remember, in children, we do not give aspirin. If they have these symptoms, we do not give them aspirin because of the contraindication of Reese syndrome. In children, only in one condition we are giving aspirin, that is Kawasaki. Okay, sorry, not Kawasaki. Oh my God. Is it? Yeah, it was Kawasaki. I forgot the name. Yes. Otherwise, we are not giving them aspirin. Then this we will do in emergency medicine. Okay. The contraception, we'll do it in detail in gynecology, but just to remember that for emergency contraception, we have two types. Either we have plan B or we have copper IUDs. In IUD, for emergency contraception, we are only using copper iodine. Okay, not the other Mirena or progestin, no. Only copper IUD is used as an emergency contraception, and copper IUD is superior than plan B. It has 99% efficacy rate than plan B. So if a patient is coming to us, she had an unprotected intercourse last night, and she comes up to us in a panic that, doctor, what do I do? And in the option, they gave us both of these, plan B, IUD, copper IUD, and some other. So what is the superiority? That is copper IUD. We will recommend her copper IUD because it is superior, 99% efficacy, even after given after 5 days. Still, it has 99% efficacy. But plan B, even given within 72 or 24 hours, the efficacy is less. So we will first, we won't force her. We will just, what our recommendation, first recommendation would be copper IUD. If she agrees, fine. If she doesn't, it's her choice, whatever she wants to take. Similarly, if we have started the patient on the emergency contraception and her menstrual bleeding did not happen within 21 days, then we have to do a pregnancy test. Okay. So we'll just do it in more detail in gynae. Then we have cough. DDs, you should know for cough, upper airway cough syndrome. Okay, that is a postnasal drip, asthma, COPD, GERD, non-asthmatic eosinophilic bronchitis, ACE inhibitors. ACE inhibitors, very important. You should know, always remember that ACE inhibitors are a cause of cough. Okay, they might give you a scenario asking you that a patient, any like 45-year patient, she recently started on her antihypertensives, and now she's presenting to you with some cough, and she doesn't know of any cause. So if they, and she has a history of blood pressure, or they might not mention started on antihypertensive. So what is the next step? First, we have to rule out, was she recently had any change in medication? Was she started on any ACE inhibitors? If she says yes, then it means that, okay, it is due to this. And what we have to do, we have to change the medication. If the patient is on ACE inhibitors and even his blood pressure is controlled, but they are experiencing the symptoms of cough, then we have to change it. We can change it with ARB or any other antihypertensive, but mostly it's instead of ACE, we give the ARB. Then aspiration, bronchiectasis, cystic fibrosis, chronic interstitial lung disease, congestive heart failure, lung or laryngeal cancer, pertussis, psychogenic restricted lung disease, and TB, atypical mycobacterium. These are all the common causes of cough. Okay, it can be, we will take the history, it can be dry, productive, what type of is it? Does it have any blood in it? Is it associated with any respiratory dyspnea, any fever, any chest pain, any postnasal drip? So all the, is it worse at night time? Are you able to sleep? So all these are the questions we are going to ask the patient just to follow to check our DDs. Okay. Then if she has any fever, constitutional symptoms, to rule out any cancer, like any lung cancer. Okay. Maybe the patient is a smoker and he's having post smoking due to that, the cough. So all of these things we have to ask the DD questions, and according to that, we will make our diagnosis. Then recent travel, any history of recent travel. Maybe the patient just traveled from a high risk area where TB is very common, South Asian countries. Okay, so they may give you a history that the patient recently traveled from a South Asian country and now they are presenting with cough. And along with cough, they have night sweats. So what is it? And weight loss. So mostly it is TB. It is also common in the indigenous population, First Nations. So according to the history, our diagnosis will change. Then ACE inhibitors, beta blockers, allergies, they can be a major cause. Similarly, how will we investigate? If our whatever we are diagnosing, if the patient is, it is due to some medication, change the medication, reduce the dose accordingly. If the patient gives a history of recent travel, then what do we have to do? We have to do the tuberculin test. Okay, chest X-ray, tuberculin test to rule out any TB. If the patient is giving us any constitutional symptoms along, old age person, 70, 80 plus, coming to you with a history of smoking along with the constitutional symptoms, so that is a red flag. That is something alarming, right? So what do we have to do? Do the chest X-ray, refer the patient to the internal medicine or a respirologist, so that further test can be done and to check out what we are going to do. But first, we're going to do the chest X-ray to rule out any lung cancer. Similarly, if the patient is presenting with a cough along with regurgitation, right? So what does it, or metallic taste in the mouth? So it leads towards the GERD. So we will start the patient on a trial of PPIs. So according to the history and the symptoms they are presenting, our investigation is going to change. If the patient is presenting with some symptoms of fever, cough, pleuritic chest pain, most probably, what is it? It can be pneumonia. Then we have dementia. So for dementia, what we have, this is just a small review. Okay, so a patient is presenting with dementia, or mostly the family members are going to bring these patients. Okay, the dementia patient, they won't come to you themselves. Mostly it would be like a family member, a daughter or son is bringing in their parents that for the last 1 year or few months, or a wife might be bringing her husband or vice versa, that we have noticed that he's forgetting things. Okay, he's forgetting, he forgets his daily activities. He's not able to do his own things, which he used to do previously. Then after the complete physical examination and history, what are we going to do? The best screening test is MOCA. It's a small test where we ask them different questions and they have to answer those. So we do the MOCA. And we always have to rule out if the patient is presenting with some memory loss, some dementia, we have to do these investigations according to the history. He might be having some thyroid issues. Okay, he might be having some cirrhosis. So anything, might be some electrolyte imbalance. So we have to do these tests according to the history to check, to rule out any organic cause. If everything is fine, then okay, it is dementia. It can be age related. If age related, treat accordingly. If no, then treat accordingly. So what are the investigations we are doing? CBC, liver enzyme, TSH, excuse me, renal function test, serum electrolytes, serum calcium, glucose, vitamin B12, folate, and VDRL HIV. Then management, we will, first of all, we will provide the patient with some calendars and clocks so that he should know orientation cues. What is the time where he is? Then we will provide optimize for vision, hearing. We will also educate the patient and the family about the fall prevention. We will start remember, for Alzheimer's disease, there is no treatment. Okay, it's a clinical diagnosis for dementia, and we are giving methyl D-aspartate receptor antagonist and cholinesterase inhibitors, mementamine, rivastigmine. We are just giving these to slow down the disease. They will not cure it. Just to slow the progression, we give this. Along with that, as the disease progresses, the patient may have some antipsychotic, they may start having, they get very aggressive, or they may have some hallucinations, all these. So for that, we can start them on antipsychotics. They may become depressed, antidepressants. So these things are going to be started if they are giving us the history. In the history, they say that, okay, a patient is coming with dementia or with Alzheimer, he is taking his medications, but now recently he has started to have some hallucinations, or he has been very aggressive, agitated, and the family is now scared of him. So what are we can start him on low dose antipsychotics, or they may say that he is very isolated now, doesn't talk to anyone, maybe he's going into depression. So according to the symptoms, we'll start the patient on the medications. Then we have depression, very important, very, very important, both for NAC, for QE, very important topic. Know these DDs, okay, for the depression. Then whenever a patient is coming, it is a clinical diagnosis, and what is the criteria? This is the criteria. If the patient has depressed mood, increase or decrease sleep, decrease interest, guilt, decrease energy, decrease concentration, decrease appetite and weight, psychomotor agitation, retardation, and suicidal ideation. If he is presenting with any 5 of these, he might not have depressed mood. He might just say that I'm normal, but these are the rest of the symptoms are there. So what is it? We diagnose him as depression. If he is presenting with only depressed mood, and along with depressed mood, he has any 2 of the other symptoms, then we mark him as depressed person. So for that, what is the best treatment for depression? We always start with cognitive behavior therapy. The first line treatment for depression is, remember, cognitive behavior therapy. If not improving, we start the patient on SSRIs. And what are the questions we are going to ask him? Little interest or pleasure in doing things, feeling down, depressed, or hopeless. He might say that previously I like to play a golf, but now I don't like to go out. I don't like to play. I don't like to mingle with my friends. I'm not able to sleep. I don't like to eat, and I'm losing my weight. So all of these are the symptoms of depressed mood. Then always screen them for any suicidal ideation. Always ask them that in the previous 2 weeks, did you ever feel like harming yourself or anybody else around you? So if the patient is depressed and he comes to you with suicidal ideation, or he has a plan, or he is suicidal, then immediately we have to involuntarily admit the patient. Okay, for suicidal patients, we do not just send them back. We have to admit them. We tell them that, okay, we need to admit you. If he agrees, well and good. But if he doesn't, then we sign a form known as Form 1, and then we admit them under involuntary admission. Because if we just send them home and they commit suicide, who is responsible? We are going to be responsible for that. So always ensure that the patient is suicidal or not. After that, what we do, is that some other routine workups like physical examination, CBC, TSH, ferritin, folate, B12, electrolyte, urine analysis, and glucose. If in the question they are giving you all the symptoms of depression and asking you the next management point of view, first, cognitive behavior therapy. If they're giving you that the patient has the symptoms and he says that he's also suicidal, then what we are going to do? Admit him. Okay. Then along with that, what are the medications we are starting the patient on after cognitive behavior therapy is SSRIs. They are the first line therapies. Okay. If SSRIs, and we monitor them for 2 to 4 weeks. If in 2 to 4 weeks the symptoms are not resolving, then what will we do? We will increase the dose. Okay, if there's mild increase in the decrease in the symptoms, increase the dose. Then monitor the patient for another 2 to 4 weeks. Still the symptoms are not getting better, then we can either add another SSRI, or we can add another medication, not SSRI, or we can switch to another SSRI. So depending, but first we have to monitor the patient. We started the patient on medication, and he comes to us after 1 week saying that, doctor, my symptoms are not resolving. So what will we do? We will tell him that you have to continue it. Okay, we cannot just change immediately after 1 or 2 weeks the medication. It will take time. And we continue it for at least 6 months. We have to counsel the patient that we will not stop them abruptly. If you stop them abruptly, there will be withdrawal effects. So just tell him we do not stop them abruptly. Once your symptoms are resolving, we will continue them at the same dose. And then after some time, if you're completely fine, we will stop them. We will taper them off slowly. So educate the patient about all these things. Then in children, the first line is fluoxetine. And always monitor them for suicidal ideation and behavior. In children, why are we giving fluoxetine? Because it has a long half-life, so it doesn't need to be tapered off also. Then psychotherapy, cognitive behavior therapy, then treatment should continue for at least 6 months. Always when starting the patient on SSRIs, do a baseline ECG. And tell them about the side effects like sexual dysfunction, impotency, decreased libido, delayed ejaculation. If we've started a patient on SSRI, right? And after he's doing well on it, for example, we started them on sertraline or citalopram, and after 2 months, he comes to us and he says that, doctor, now I have some erectile dysfunction. I didn't have it previously, but now I have it. But his depression symptoms are completely resolved. Okay, so what we will do? We will give him sildenafil. We won't stop that because his symptoms improved with it. So we will give him sildenafil. But if the patient is coming to us with depression along with ED, then we are not going to start him on SSRIs because he already has a problem, sexual dysfunction. Then we can start him on bupropion because it has less sexual side effects and it is preferred over in patients who have any sexual side effects. Okay. So just you should know these small things. Then what are others like SNRIs? These are venlafaxine, duloxetine, and side effects are insomnia, tremor, tachycardia, sweating. Similarly, for bupropion, it is headache, insomnia, nightmares, seizures. And TCAs can be given, which are sexual dysfunction side effects, weight gain, tremor, tachycardia, and sweating. Okay. Next, we have diabetes. In diabetes, the patient, we all know it is a metabolic disorder with increased blood glucose level. So the patient might present to you with symptoms of hyperglycemia, might present you for the first time with DKA in the emergency department. He might be diabetic and he never knew it, and he ended up with DKA in emergency department, or might present with hypoglycemia. Okay, so he can give any one of these presentations. So what are the symptoms of hypoglycemia? It is polyphagia, polydipsia, polyuria, weight change, blurry vision, yeast infection. Similarly, for DKA, fruity breath, anorexia, nausea, vomiting, fatigue, abdominal pain, cosmal breathing, dehydration. For hypoglycemia, hunger, anxiety, tremor, palpitation, sweating, headache, seizure, fatigue, confusion, and coma. So it's not necessary that he'll just present with symptoms of hyperglycemia, or he might just be obese and we are checking and he has hyperglycemia. He might come to us with hypoglycemia. He might end in the emergency department with hypoglycemia, with some seizures. And when we do his blood capillary blood glucose, it might be very high. So any one of these can be the presentation. Just remember, and DKA is most common in type 1 diabetes. Mostly in children, they land in the ED with DKA symptoms. And on further investigation, they get to know that, oh, they are diabetic. What are the complications? Micro and macrovascular complications. The microvascular complications are nephropathy, retinopathy, neuropathy. And the macrovascular are coronary artery disease, cardiovascular disease, and peripheral vascular disease. In indigenous population, it is common. If an obese indigenous person is coming, always screen them for diabetes. Okay. Then the risk factors, type 1 is autoimmune, more common in children. Type 2 has a history of first degree relatives, age more than 40 years, obese, hypertension, hyperlipidemia, coronary artery disease, vascular disease, prior gestational diabetes mellitus. Macrosomic baby, he's at risk of later in life having diabetes. PCOS, very important. Then history of impaired fasting glucose or impaired glucose tolerance test. Then presence of complications associated with diabetes mellitus, presence of any of these. Along with it, medications. If we are starting the patient of any of these medications, we will do their baseline blood glucose levels, and then we will monitor them and educate them that, okay, they might have an increased blood glucose level. Okay, the side effect might be diabetes, and we will have to monitor you on that also. And glucocorticoids, atypical antipsychotics, and antiretroviral medications, all of their side effects is diabetes mellitus, increased blood glucose levels. Then what is the screening test? The screening test is the one which we are doing above 40 years, similarly like we did for dyslipidemia, right? So in normal population, we are starting above 40 years every 3 years with fasting blood glucose or hemoglobin A1C. If they are normal population at age 40, we're going to start the screening test. Also in the mothers, the pregnant ladies, every pregnant lady has to be, we have to do this at 24 to 28 weeks. Why? Oral 75 gram oral OGTT test. Okay. So at 24 to 28 weeks, we do conduct a blood glucose test for them. These are just the screening tests, not the diagnostic. Okay. For diagnosis, what will we do? We do either hemoglobin A1C, fasting blood glucose, and oral glucose tolerance tests. Either two other tests are positive, or the patient is presenting with symptoms of hyperglycemia and one of the tests being positive. Then we diagnose them as hyperglycemia. Okay, diabetic, sorry. Okay, then okay. So in diabetes patient, what should be the glycemic control be? A1C should be less than 7%. Similarly, their blood pressure should be less than 130 by 80. Remember, for diabetic population, the blood pressure level is this, 130 by 80. This is important. They do ask this. Okay, if a diabetic person is coming to us and his blood pressure is 140 by 80, we will start him on ACE inhibitors. Okay, cholesterol level, same, less than 2. LDL less than 2, same for everyone. Drugs, consider ACE, ARB, statin, and aspirin. And exercise, eating proper diet, and smoking cessation. So what are we doing in the assessment of the patient who has diabetes? Initial assessment, we'll ask about all the symptoms. Then in the history, after 2 to 4 months, what are we doing? Again, in the history, same history. Ask him about any episodes of hypoglycemia, any episode of DKA, and do they smoke? If they smoke, counsel them. Ask them whether they are taking their medications properly or no. And annually, we will screen them for awareness and same frequency of hypoglycemia in the 1 year. Did you have any episode of hypoglycemia, DKA, what if mostly these patients, they do go into depression, because these are long-term, lifelong morbidity. So these patients do, due to taking regular medications and everything, they can go into depression. So we always have to screen them for depression. Then in physical examination on the initial visit, we do the regular examination like height, weight, BMI, blood pressure, waist circumference, any fundoscopy, any thyroid exam. We will check for any cardiovascular examination, abdominal, hand, foot, and skin. Then every 2 to 4 months when they're presenting, we will repeat their weight, BP, BMI, and waist circumference, just to monitor them if it's increasing or decreasing. Annually, foot examination with 10-gram monofilament. You should know what are we doing the foot examination with. Okay, it is 10-gram monofilament to check for any neuropathy. Investigation at presentation: fasting blood glucose, hemoglobin A1C, then fasting lipids, creatinine, urine, albumin creatinine ratio, baseline ECG. Sorry. Then repeat testing every 2 years for those at high risk. Similarly, at every 2 to 4 weeks, 2 to 4 months, what are we doing? Every 3 months, we have to do hemoglobin A1C. These are the diabetic patients we are talking about, not the normal population. In diabetic, once a patient has been diagnosed, so we will monitor them with hemoglobin A1C every 3 months. Then annually, we have to do their lipid profile and albumin creatinine ratio to check for any abnormality or damage to the kidneys. Similarly, we will educate them about we will educate them about the nutritional and physical education, tell them to do more exercise, eat a healthy diet, avoid high sugar food, avoid high fatty food, then monitor their blood glucose regularly at home. And in type 2 diabetes, when the patient is presenting at presentation, we will do fundoscopy, like refer them to ophthalmology, okay, to check their eyes. We will check for their any kidney damage, okay, for micro and macrovascular complications in type 2 diabetes. But if somebody is presenting with type 1 diabetes, so all of this screening will start after 5 years, not at the time of presentation. Okay, then every 2 to 4 months, what are we going to do? We are just going to assess them that if any complication is developing or no. Then annually arrange for retinopathy screening and influenza and pneumococcal vaccination. Okay, so this is the chart. We should know that if the patient has been diagnosed with type 2 diabetes or his hemoglobin A1C levels were high. So depending upon the A1C level, the management changes. Okay, if the patient is presenting and his A1C levels were less than 8.5%, then what we are going to do? First, lifestyle modification. Okay, if within 2 to 3 months after lifestyle modification, the glycemic targets are not achieved, then we will start them on metformin. Okay. Similarly, if at presentation the A1C level is more than or equal to 8.5, we will immediately start them on metformin. Okay, we will not wait for lifestyle modification. We will immediately, along with lifestyle modification, just start them on metformin and then monitor them. But if the patient is coming to you with a DKA, he's coming with very high A1C levels, very high glucose levels in the emergency department. So we have to initially start him on insulin. Okay, after starting the patient on insulin, then after that, what we will do? We will monitor the patient, and once the glycemic level has been achieved, we can switch that insulin to metformin. Okay, so depending upon the presentation, the levels, the initial management changes. So what we do, if the patient is started on metformin and now even then his glycemic targets are not achieved, the hemoglobin A1C or blood glucose levels, they are not decreasing, we will add another anti-hypoglycemic depending upon the condition. if the patient has any underlying heart disease, like he has congestive heart failure, so the first line antihypoglycemic is SGLT2 inhibitors. What are these? The gliflozin, canagliflozin, empagliflozin. So these are the ones we are going to add, okay, because they are preferred. And in congestive heart failure, they are also now considered to have the effect in mortality also, prolong it. Okay, so in congestive heart failure, if they're giving you a scene, the patient scenario in which they tell you the patient has congestive heart failure, along with it he's diabetic and he is taking his medications or insulin and his it's not helping him, then what other medication we can start, or is the best, that is SGLT2 inhibitors. Similarly, if after starting another antihypoglycemic, the patient is not, he's not getting benefited, so what will we do? We will increase the dose or add another antihypoglycemic, and then keep on monitoring the patient. These are all the name of the medications. Okay, and remember, we do not need to know the doses of the medications. I don't know if I mentioned it before or no. Just remember the name and the route. They will not expect you to know the doses, but they do expect you to know the name of the medication, the time duration, if it is less or for lifelong, and if what is the route we are giving it through, oral, IV, subcutaneous, any. So we should know that. Then what are we supposed to consider? If the patient has a macrovascular disease, he's diabetic and he has symptoms of macrovascular complications, right? If he is above 55, just diabetic and above 55 years of 55 or above years of age, or diabetic 50 less than 55 years and he has some microvascular complications. So we have to start them on ACE or ARBs inhibitors. Okay. Similarly, if he has clinical macrovascular disease, age is 40 years or more, age is less than 40 with any of the following, that is diabetes more than 15 years, age above 30 years, and any other cardiovascular risk factor. So we will start them on statins, even if their LDL level is normal, even if their blood pressure level is normal, within the normal range, but any of this criteria is present, start them on statin, ACE inhibitors, and aspirin. We start them on low dose aspirin for the prevention of any cardiovascular disease. Next topic is dizziness. Okay, for dizziness, this is more important for NAC point of view. It is. Okay, so for what is dizziness, we need to know first differentiating point. Either it is vertigo or non-vertiginous. In vertigo, what will we ask the patient to differentiate it from non-vertiginous? That is, do you seem that the external world seems to revolve around you, or individual revolves in space? If he comes to you, he says that I have some dizziness, and he says that I feel that everything around me is revolving, everything around me is moving, then most probably it is vertigo. Okay, but if he says that no, I'm just feeling dizzy, lightheaded, disoriented, or sometimes I just feel that I'm confused, I don't know where I am, then it is non-vertiginous cause. According to that, if it is vertigo, it can be either central cause or peripheral cause. In central, it can be due to some brainstem or cerebellar cause, and the etiologies can be any tumor, stroke, drug, multiple sclerosis. In peripheral, inner ear, vestibular, idiopathic, Meniere's disease, BPPV, acoustic neuroma, trauma, drugs, labyrinthitis. Then for non-vertiginous, what could be the causes? Psychogenic, it is diagnosis of exclusion. You do all the tests, you do everything is normal, nothing is there, then it is psychogenic. Vascular, it can be vertebral basilar insufficiency, basilar migraine, DIA, orthostatic hypotension, all of these, any one of this, it can be vasovagal episodes, arrhythmias. And ocular, it can be due to decreased visual acuity. Maybe the patient is wears spectacles and his visual acuity is changing and he didn't get it changed. And because of that, he feels lightheaded or disoriented. So we need to always check that also, take into account. We can't always just jump on to the very, what you call, the serious or the most dangerous diagnosis. Always start with the minor ones. Okay. Then in BPV, what it will be, the sudden onset will last for few durations and nothing else. The patient will come into you and he'll say that, doctor, I feel dizzy when I just move my head, or when I just get up from sitting position, and it lasts for a few seconds and then it just disappears. In labyrinthitis, they may give you a history of any recent fever, any viral infection, and now they have this vertigo. Along with this might say that, okay, this dizziness lasts for few days, and during this, I do also have some hearing problems. I'm not able to hear properly, or I do listen to some voices. So this is what happens in labyrinthitis. In Meniere's disease, gradual onset lasts for minutes to hours, and there's hearing loss and tinnitus. How do we differentiate between both of these, labyrinthitis and Meniere's? Labyrinthitis, sudden onset, and may have a history of infection and last for days. Okay, Meniere disease, gradually. They will just come that I had this, but now I feel like it is increasing. Gradually, it is increasing, and now it lasts for minutes to hours. Then acoustic neuroma, mostly in elderly. Okay, so insidious onset, chronic, it has all the, it is due to like neurological symptoms they might have. They have tinnitus and hearing loss, and mostly elderly will present with it, and unilateral hearing loss would be there. So then we have to differentiate. How will we differentiate? Similarly, for vestibular, worse with head movement or eye closure, no change with head movement or eye closure, non-vestibular, and worse with exercise is most commonly pulmonary or cardiogenic cause. Then along with that, what do? We do the physical examination. In cardiogenic, we will check for any orthostatic changes in the blood pressure. Like we'll ask the patient to sit and then stand up, monitor the blood pressure both the times, lie down and then stand up, monitor the, so we'll check for any orthostatic changes. Similarly, for the PPV, what is the test? Diagnostic test. It is clinical diagnosis. Okay, so we are doing the Dix-Hellpike maneuver. And after that, when if this maneuver is positive, the test is positive, what is the treatment? It is also Epley's maneuver. So we will educate the patient how to do this Epley's maneuver at home, and then we'll tell him that, okay, it is going to get fine after a few days or within some time. So for BPPV, Dix-Hellpike maneuver and Epley's maneuver. Similarly, for any disequilibrium, we have to do the Romberg test. We are going to do all this in neurology. Don't worry. Okay. And if he is saying that he has any nausea, vomiting with it, we can give him any antiemetics, or if any other, like he is taking more caffeine or more, what do you call it, coffee, alcohol, we have to educate him about that also, that you have to stop it. Okay, he might be on any furosemide. He might be a patient of any congestive heart failure. So then furosemide is also one of the cause, okay, of dizziness. So we might need to reduce the dose. So depending upon the whatever his cause is, we will educate him and treat him properly. But here, what is important? BPPV is important. So you should know if the patient is presenting with BPPV, we have to do the Dix-Hellpike maneuver, and Epley's maneuver is the treatment. Domestic abuse, very important. Just remember, domestic abuse, if it is a spousal abuse, it is an even elderly abuse. It is not a reportable disease. We will counsel the patient. If the patient agrees, then we will report it. Otherwise, we will not report it. Okay, so what do we do in domestic abuse? The patient will gonna come to us, and she might present you with some bruising, some fall. They might tell you that, okay, it was a spousal abuse, or they might not. They just give you a vague history, and they may give you a history that, okay, a patient, she comes to you every month with some abdominal pain, headaches, cramps, and on history, everything is normal. So this is one of the red flags for abuse. Okay, and because these patients are scared, so they will not discuss it with you. So we have to take an approach where we We tell them that, okay, it's a confidential matter. We will not disclose it to anyone, but you can share it with us. Okay. And if the patient shares it with us, then what will we do? We will educate them. We do need to tell them that, okay, it is not their fault. Whatever is happening, it is a crime, and we have to take it as a crime. Then what will we do? We will educate the patient about the safety plan. Okay. We will educate them if they are not ready to move out, if they are not ready to report it, they are still there in the relationship, then we will tell them a safety plan. And what is that safety plan? We will tell them that always keep an emergency bag. In that emergency bag, keep these items. Important. Okay, this can be a CDM question that you have. A person comes to do a married lady, and she has a history of abuse, but she does not want to report it. What is the next step? So the next step is make a safety plan with the patient. Then after making the next question, after making this safety plan, what are you gonna tell the patient to keep in the emergency items or anything like that? It could be any way they can ask the question. So we should know what are they going to include in their emergency items: money, clothes, keys, the important documents, and medication. So they should have this prepared bag with them whenever they feel they need to move out, they need to leave, so that they can just quickly leave. Okay, they don't need to just pack everything. So the bag should be ready with them. And if a patient is coming to you, a lady is coming to you, she is married and she is in an abuse, always ask about children. Are there any children in the family? Because if the children are there and the children are also the part of the abuse, then we have to report it. We will report it to the CAS. We will not report about the mother, but the children we always have to report, and we will report it to the CAS. So these are few small points we should know. Similarly, if an elderly is coming to you and they might present with some wake symptoms. Okay, so it can mostly in elderly, it is due to they're very sick, they have some issues with, they are dependent on their family members, and the family members can't take care of them, but they just keep them because of some financial benefits. So they might be experiencing some abuse because of that. So if they agree, we will counsel them. If they agree, we will report it. But similarly, if we see that an elderly patient is coming to us and he is in any housing society, like in an elderly house, he's in some other facilities, old age, okay, at that time, we have to report it. Okay, if he is living in some shelter home, in some old age houses, then we will report it. We will not take his permission, because at that time the staff is abusing him, right? So we have to report it. But here, if he's at his home, with his family, and he's not agreeing to report him, we will not report it, but we will counsel him. Okay, and all of these cases will be documented. We have to document them. Will not report without patient's consent, but we will document them in our notes. Then we have dyspepsia. What is dyspepsia? It is the epigastric pain or discomfort. Okay, it is epigastric pain or discomfort associated with fullness, belching, bloating, heartburn, food intolerance, nausea, vomiting. Remember, dyspepsia and GERD, they are two different things. Okay, and GERD, we have regurgitation. In dyspepsia, the patient can present with just epigastric pain or discomfort, but they can be interlinked. Dyspepsia can be a cause of GERD. Okay, now, but if it's not necessary that always if a patient has GERD, he has dyspepsia, or the patient has dyspepsia, he has GERD. There are two different things. Then what are the red flags for dyspepsia? Weight loss, dysphagia, persistent vomiting, GI bleeding, hematemesis, hematochezia, melena, and onset age is more than 50 years. So if the patient is above 50 years and he is presenting to you for the first time with dyspepsia, it is a red flag. We have to further investigate. Okay, but if he is 40 years, like 30 years, a young patient, and he's presenting with dyspepsia along with some regurgitation, metallic taste in the mouth, or he says that at night time when I sleep, I'm not able to sleep properly. So it can be GERD. So what will we do? We will first start him on a trial of PPIs. But along with dyspepsia, if he has some constitutional symptoms, he has some weight loss, he has some fever, he has some vomiting, and he's about, like, he's 60 years old. So we have to do the endoscopy. Maybe it's a cancer. So all depending on the presentation, our investigations are going to change. So the common causes are functional, peptic ulcer disease, GERD, and gastritis. Other can be like IBS, cholelithiasis, gastric cancer, pancreatic cancer. Then history, symptoms may not be useful in finding the cause. We have to further investigate, further take a detailed history, see what's going on. Is it associated with any eating, anorexia, nausea, vomiting, alcohol use, any NSAIDs use? Maybe the patient is using a lot of, he has some other problem for which joint pain, any back pain for which he's using NSAIDs, and he is using it chronically. And that those NSAIDs might be leading him to peptic ulcer. And that peptic ulcer is leading to dyspepsia. So all of these things are interconnected. Then if less than 60 years old, without any high-risk features, what are we going to do? H. pylori test using the urea breath test or serology. But we are not directly going to jump to H. pylori test, okay? First, we have to see if he's giving us the symptoms of GERD, we have to treat him accordingly. If he's taking any NSAIDs, treat him accordingly, reduce the dose, switch it. And then if even after that, his symptoms are not resolving, we treated him on a trial of PPIs, the symptoms are not resolving. Now, what we will do, we will do the H. pylori test using the urea breath test. And if the H. pylori test is positive, what will we do? We have two therapies, which lasts for 10 to 14 days. It's written 14, it's 10 to 14 days. Okay, you should know the duration. It can be either in bismuth quadruple therapy or non-bismuth quadruple therapy. What are we giving the patient? PPI, standard dose, then bismuth subsalicylate, metronidazole, tetracycline. Either these four together for 10 to 14 days, or we are starting the patient on PPI, clarithromycin, amoxicillin, and metronidazole. And after 10 to 14 days, we are going to do the check for eradication of H. pylori. And that we are going to do with this same urea breath test. Okay, so start the patient on treatment. If positive, then after 14 days, we have to recheck for the eradication of H. pylori. Then it's the same, I have talked about it. If he has any like vomiting, nausea, vomiting, give him metoclopramide. Then if the patient is above 60 years, now above 60 years, we have to do upper endoscopy to rule out any organic pathology. He might be having some cancer, some other serious disease. So in old age, cancer is very common. And always remember, if patient is presenting in old age first time with any symptom, he hadn't had it previously, and he's presenting with it for the first time, or he has a symptom and along with it, he has some constitutional features, always further investigated. It can be an underlying cancer. It can be an underlying malignancy. So we do upper endoscopy in them, okay, in old age. Then we have dyspnea. What is dyspnea? It is a shortness of breath, difficulty breathing. And in this also, we should know the, what is it? The DD. The DD is important, okay? Just remember this DD. If you remember, previously they didn't used to ask the DDs in the CDM questions, but for the last 2 years, they have started asking DDs also. They give you the scenario and they ask you, okay, what is the DD? And after DD, they ask you, what is the next step? So, and this DD, if you learn it now, it will be helpful for you in the, for NAC also, because in NAC, it's all about DDs. You have to know the DDs and they ask you about the DDs. The first question is the DDs. So just learn them. So if the patient is presenting with dyspnea, What we have to do? Further history, physical examination, investigations. If the dyspnea is a lot, remember everything is happening in the office setting. He's coming, he's breathless, oxygen level is very low, immediately refer to the emergency. But if it's mild, not a oxygen level is fine, okay, and he's giving some other symptoms like night sweats, fever, weight loss, maybe he's having some lung cancer, so we have to investigate that further. Maybe he's having some pneumonia, it's a clinical diagnosis, so we will start him on antibiotics. Maybe the patient is presenting with this dyspnea and he or she has asthma, so we have to treat accordingly. So depending upon the presentation, the treatment will also change, okay. The investigations we are doing: chest X-ray, ECG, pulmonary function test, and ABGs. Okay, and what? Look, sent to the emergency department if severe distress. So if in the scenario they're giving you, the patient is presenting to you, he's talking in small words, or he's not able to complete his sentences, his oxygen level is low, he's in respiratory distress, respiratory rate is above 30, he has some cyanosis of the lips, what are we going to do? Immediate send to this emergency department. They didn't give us any management because it is an emergency case. Dyspnea cannot be treated in the office setting. Then we have dysuria. In dysuria, it gives the sensation of pain, burning, or discomfort when urinating. Okay, and it is of different types. In different conditions, it can present with different symptoms. So all of these are the DTs. If the patient is presenting with UTI or cystitis, what is the most common cause? The Keeps bacteria. Mostly it's the E. coli. E. coli is most common. 80 to 90% of the causes are due to E. coli. Then rest of the other comes in. So how will he or she present? They will present with dysuria without maturation, frequency, urgency, incontinence, hematuria, nocturia, back pain, suprapubic discomfort, and low grade. Mostly in UTIs, they don't have fever. They will just present and they will say that I have frequency and urgency, okay, incontinence in mild cases. They'll just come with that. And then in the office, what we can do the urine dipstick. So if the urine dipstick is positive for nitrites and leukocytes trace, and the patient has symptoms of dysuria, frequency, urgency, then what is it? It is UTI. If just on urine dipstick, the patient is presenting with dysuria or frequency, urgency, and along with that, we did the urine dipstick and only leukocytes were positive, it is UTI again. If only symptoms and only nitrites are positive, okay, the leukocytes are not there, still it is UTI. Maybe the patient doesn't have the symptoms and on urine analysis, urine dipstick, both of these are positive, still they have UTI. But remember, if the UTI, we are doing some routine test and the test comes out to be positive for UTI, if the patient is asymptomatic, we are not treating it. Only in pregnancy, when the patient is even asymptomatic, then we have to treat UTI. In normal population, if they are asymptomatic and the urine analysis shows that they are positive for UTI, even then we will not treat them. Okay, we won't start them on any antibiotics. Only if they are symptomatic, then we will treat them. Then for urethritis, they will present with you some discharge, urethral or vaginal discharge, any history of STI. Then they might be having multiple sexual partners, high sexual behavior. So all of these are the risk factors for urethritis. And the common causes, chlamydia trachomatis and gonorrhea, the most common causes. And the commonest of all is chlamydia trachomatis, okay? Then for vaginitis, what are the causes? Candida, Gardnerella, Trichomonas, trachomatis, herpes, and lichen sclerosis or atrophic. Atrophic vaginitis occurs in postmenopausal women. So it can be, the sinus symptoms are external dysuria, pain, vaginal discharge, irritation, dyspareunia, abnormal vaginal bleeding. So maybe a postmenopausal woman is coming to you and she's giving you the signs of dysuria and frequency, urgency. So it is mostly postmenopausal genitourinary syndrome. And in that, what will we give her? We will give her local estrogen cream. Similarly, for prostatitis, they will have a history of any STI, high sexual behavior. They might be homeless, and they might be sex workers, male also. So, and on a DRE, they will have a very tender prostate, and we do not usually do DRE on them. Okay, and then dysuria, fever, chills, urgency, frequency, and tender prostate. So how will we know the prostate is tender? It's on DRE. Okay, then pyelonephritis, E. coli, then Spirophyticus, Enterobacter, Klebsiella, Proteus, Pseudomonas. These are the common causes for pyelonephritis. And in pyelonephritis, what will they present with? Costovertebral angle tenderness. Common, very important. They will have fever, costovertebral angle tenderness, along with that frequency, urgency, dysuria, nausea, vomiting, pain radiating to the groin. So it is the sign of pyelonephritis. So presenting on the symptoms, whatever the symptoms are, we are going to treat the patient. Okay. So after the history, asking about all these symptoms, we will, if it's just simple UTI, what we can do in office, we can do the urine dipstick test in office. Okay. Remember. And according to that, we can start the patient on antibiotics. If the urine dipstick test is positive, start them on antibiotics, then send a urine culture and sensitivity. Then according to the urine culture and sensitivity, if needed, we can change the antibiotic. Okay. Then we will also do order urine RM, routine and microscopy for any check for any pus, pyuria, bacteriuria, and hematuria. If any, they are giving the complaints of any discharge, any STI, then what we have to do along with urine analysis, we have to do wet mount to rule out any other cause, like any STI, like gram staining, we can do KOH. For gonorrhea and chlamydia, what we do is NAT. NAT is preferred. We do that. If the first line treatment for UTI is what? Trimethoprim, sulfamethoxazole. Okay, for 3 days. And nitrofurantoin. These are the first line treatment. So we start the patient on any one of these. If needed, we can change later on. Similarly, in pregnant women, even if they are asymptomatic, whenever a pregnant woman is coming to you for the first time checkup, we have to do culture and sensitivity, urine culture and sensitivity to check for any bacteriuria. So if she's coming to you for the first time, and for her routine checkup, we do culture and sensitivity, it is positive, even though she's asymptomatic, we will start her on treatment. Okay, because there's a high risk of preterm labor, pyelonephritis, low birth weight, mostly preterm labor. So to prevent it, we always treat them. And it is for what we give in pregnancy is amoxicillin, nitrofurantoin, and cephalexin. And if the patient has recurrent UTIs, more than a history of more than 3 times a year, we will give them prophylactic antibiotics. And what are those? These are the same: trimethoprim, sulfamethoxazole, or nitrofurantoin. We give them prophylactically. We also educate the patient to maintain good hydration, avoid feminine hygiene spray and scented douches, empty bladder immediately before and after intercourse, vaginal estrogen therapy for peri and postmenopausal women for recurrent UTIs. Okay. Also, if a patient is, okay, I'll discuss this down in the discharge. Yes, and then for urethritis, same. And remember, the STIs, we have to report it to the public health. And for chlamydia, gonorrhea, syphilis, HIV, these are which we have to treat the partner also. Okay, remember, we can't just treat the patient and let them go. We always have to ask them about their sexual partners, and we have to treat them. We will ask them first, we will educate them to tell their sexual partners themselves. If they are not, then it is our duty to report to the public health, and they will reach out to them. Okay, it can be an ethic question. All the patients should return 4 to 7 days after completion of therapy for clinical evaluation, whether the symptoms are resolving or not. Then we have erectile dysfunction. Erectile dysfunction, it can be organic or psychogenic. And what is the one question that helps us differentiate between the two is the morning erections. Okay, in erectile dysfunction, if the morning erections are present, it is psychogenic. If they are absent, it is organic cause. So this is the one important question. If they give you a CDM question and they're just asking you one question, how will we differentiate? Then we will ask about the morning erections. Then the onset, whether it is inorganic, it is going to be gradual onset. In all the circumstances, it's going to be there. It's in a constant course. Non-coital erection would be poor. Morning erections will be absent, and all of these will be secondary. They won't be the first line. But in psychogenic, acute onset, all of a sudden he will come and he'll say that now I can't erect anymore. Then it will be situational. Depending upon situation, he might be fine, but in other situations, he might not be able to erect himself. Similarly, the course will be varying. Non-coital erection would be there and morning erections would be present. He might give you a history of psychosexual problems, partner problems would be there, and anxiety and fear would be there. So this is the main chart you should know for erectile dysfunction. Okay. Then if a person is presenting to you, they give you a scenario and they say that he's presenting to you with erectile dysfunction and everything else is fine. So we will always start with these three tests. We will do fasting glucose, hemoglobin A1C, lipid profile, and we will in the office, we will check his blood pressure. Maybe he's hypertensive and he doesn't know about that. Maybe he has dyslipidemia. Maybe he has hyperglycemic. These are the major causes of erectile dysfunction. First, we have to rule out these. After that, this testosterone, prolactin, all of these are later on. First, we always, when a patient presents with erectile dysfunction, we have to do these basic tests. Okay. And if any one of this is present, then we have to treat that. Along with that, we will treat erectile dysfunction. And for that, what we mostly use is sildenafil. Okay, so it is given phosphodiesterase type 5 inhibitor that is given to the patient. And we will also educate him about if he's alcoholic, smoking, doesn't exercise, to stop smoking and alcohol and increase your exercise. Okay, we will also provide them if he comes up to us and he says that because of this, I'm having some marriage issues, I'm having some partner issues. So we will provide them with some sexual and relationship counseling. And the first type medicine is phosphodiesterase inhibitor. Then later on, we can provide them with vacuum devices, depending if they are contraindicated. Like what are they contraindicated in? If the patient has a history of hypotension or if he's taking nitrates. So he cannot take sildenafil. In that case, we can give him vacuum devices. Next is fatigue. For fatigue, know this chart, all the highlighted ones, okay? What are those? It can be psychogenic. It can be due to any depression, lifestyle stresses, obstructive sleep apnea, sleep disorders. It can be due to a recent stroke. It can be due to some infections, any anemia, any malignancy. Malignancy is a very common cause of fatigue in old age. Anemia is very common. Then drugs, the patient might be taking any of these drugs and he might be experiencing fatigue. Then substance misuse or hypothyroidism and diabetes mellitus. These are the most common causes. What are the investigations we are going to do? Psychosocial causes are common. So first we have to, if the patient is presenting to us with fatigue and with symptoms of hypothyroidism, like she says, I'm obese, I'm gaining weight, I have dry skin, I remain constipated most of the time. So what will we do? We will do the TSH. Similarly, if the patient is coming to us and she says that I'm a vegan and I'm on a vegetarian diet for the last 10 years or 5 years, so most probably it can be vitamin B12 deficiency. And now she's presenting with fatigue and some other symptoms. So we have to do vitamin B12 levels. The patient might present to you and he says that I'm not able to sleep at night properly, or I keep on sleeping during my office. I just fall asleep and then I again wake up, and when I get up in the morning, I'm so fatigued, I'm so tired. He might be obese, he might have a history of hypertension. So it can be obstructive sleep apnea. So whatever he's going to give us the history, we are going to run those tests. Very important, beta HCG. What if she's pregnant? The patient might come up to you and say that I have an irregular menstrual history, and mostly my periods, they occur after every menstrual cycle is more than 2 months. like sometimes after 2 months, sometimes 3 months, and she gives you a history of amenorrhea. So we have to do the beta HCG to check maybe what if she's pregnant. Okay. So according to the history, our investigations are going to change. Okay, but basic investigations, if the patient is coming with fatigue, not giving you any history, nothing, just fatigue, we will do this. CBC differentials, electrolytes, 1-creatinine, ESR, glucose, TSH, ferritin, vitamin B12. And if they are giving you just one line, what is the next investigation? No history, no nothing. Just fatigue. Next investigation, CBC and differential. It will give you lots of things. But if it's female, amenorrhea, any other symptoms, history, beta HCG. Okay, then whatever the underlying cause is, we're going to treat them. And mostly in psychogenic, we just keep the patient in regular follow-ups and then tell them that it is of psychogenic etiology. There's no underlying cause, and nothing can be. We can give them some cognitive behavior therapy, some counseling, provide them with some social groups. That's it. For chronic fatigue, if the patient has these 3 criteria, he or she has chronic fatigue. It is most commonly in females. What is it? A substantial reduction or impairment in the ability to engage in pre-illness levels of activity that is lasting for more than 6 months, accompanied by fatigue of new onset, not alleviated by rest. Okay, post-exertional malaise, that is worsening of the symptoms after physical, mental, or emotional exertion that would not have caused a problem before the illness. And unrefreshing sleep. The patient comes to you, she says that I sleep for full 8 hours, I have a proper sleep, but still when I get up in the morning, I am, still I feel fatigued. So the 3 of these are present. The patient has chronic fatigue syndrome, and just a clinical diagnosis, it can be fibromyalgia. We will, for the females, what will we do? We will promote sleep hygiene, provide with them some exercises, some yogas, and if any other symptoms, treat accordingly. If they're coming with depression, gives antidepressants. If they have some complaining of aches and pains, muscle pain, any body pain, give them NSAIDs. Any anxiety because of that, anxiolytics. So depending upon the symptoms, just symptomatic treatment, and along with that, supportive management. And these patients, we put them on regular follow-ups. Then we have fever. Yes, fever also, whatever the underlying presentation is, history according to the history, and we'll treat that. So it's fever in peds, it is more important in the pediatric age group, that how we are going to treat it. In neonates, less than 28 days, what is the criteria? Above 28 days, what is 3 months more? What is the, so over there, we're going to discuss it in more detail. Okay. Similarly, for headache, it is more important in neurology. So it's more given in detail in neurology. But for migraine, what is the screening test? For migraine, what pulsatile quality over 4 to 72 hours, unilateral, nausea, vomiting, disabling intensity. If any 4 or more are present, the diagnosis is likely. Okay, and in children, they might not present with unilateral. They just present with overall headache or over headache in migraine. So remember, in children, they might give you a history that a small child is here and he has a history of headache all over the head. And along with it, he does have nausea, vomiting, and some photophobia. So he's irritable. It lasts for a few days in a month, like for every month it comes for 1 day or 2 days, and then it goes. So it can be migraine. In children, it is not unilateral. Okay, this also we're going to do in neurology. Explain better over there. Then for hearing impairment, what do we have? Remember, all the children born here in Canada, North America mostly, it is the universal screening. I don't know about other countries where Asia or no, they do it at birth or no. But here in North America, every child who is born, they do have a screening hearing test on them. Okay, and according to because it's a normal screening process, they have to test the baby for any hearing impairment. So it is a screening test which is done at birth. Then in old age, what is the screening test that we are doing? It can be whispered voice test or tuning fork test. Tuning fork is not mainly used for the screening assessment. It is the whispered voice test. And if the whispered voice test is positive, then we move to the diagnostic test. They might give you a scenario where an old age person is coming and the wife is bringing him, and she says that for the last few months, 4 to 5 months, the husband doesn't like to sit in family meetings. He sits more near to the a television. I keep on calling him. He doesn't hear to me. So what are we doing? We are doing the whispered voice test over here. Then if they ask you what is the screening test we are going to do, it's the whispered voice test. And if they're asking you what is the one diagnostic test we have to do, then that is audiometry. Okay. So depending upon the question, it changes. But we do the whispered voice test in old age. Above 60, they are coming to us for the normal visit. So we have to do the whispered voice test. Maybe the people, maybe they do not recognize it themselves. Mostly the family members are going to bring them, and they themselves don't recognize that, okay, something is going on wrong, until completely they're unable to hear. So if it's decreasing slowly on every visit in old age, we have to do whispered voice test. For tuning fork test, it helps us to distinguish between conductive and sensorineural hearing loss. So what I would ask you to do is go to Google and write how to differentiate between sensorineural and conductive hearing loss with tuning fork test. There are two tests, Rennie's and Weber's, and a chart will come out. Just remember that chart, okay? For any test, if it lateralizes here, it is sensorineural. If it does this, it is conductive. So just memorize that chart. And if they ask you any question that in Weber test, this is the result. So is it either conductive or sensorineural? If you know that chart, you will be able to identify it. Okay. So just on Google, write it. They will mention it, take any chart you like, select it and memorize it. Then if the patient, we did in the periodic health examination, right? In the visits, what will we do over there? That we have to ask for the hearing protection and noise control. What if the patient is working in a he is working near machineries, he is a pilot, he works in Air Force airports. So these are the areas where these are not very noisy areas. He's working in a factory where there are high sound machineries. So we always have to counsel them and provide them with proper hair protection. Okay. With unexplained unilateral hearing loss, sensorineural always urgently provide the patient with steroids and refer them, okay, to an ENT. Then what is next? If the patient is presenting old age with progressive, slow, unilateral hearing loss, it can be a malignancy, acoustic neuroma in old age. So keep that in mind. Old age presented with progressive hearing loss, some other neurological symptoms, it can be acoustic neuroma, and we have to refer them to the ENT. So refer patients who have an unknown etiology to an ENT specialist, experience sudden sensorineural hearing loss to an ENT specialist for ongoing care. Provide them with treatment is provide with hearing aids, okay, assistive devices, cochlear implants. We don't do that. We provide them with a hearing. This is the cochlear implant and all this. This is the ENT one, or the ENT surgeons will do it. Okay. Then we have hypertension. Just check how much time is left. Okay, we have 10 more minutes. We'll do this. Okay, then for hypertension, we'll move on to this table. If you know the table, you know the diagnosis. If a patient is coming to you in the office and we measured his blood pressure to be more than 140 by 180 by 110, or he came to you and he said that my home readings are this, or he went to a pharmacy, he got his regular checkup and they referred, he asked him, they told him to, okay, now you have to go to meet your doctor because your readings are this. If the readings are above 180 by 110, then he's hypertensive and we have to start treating him. But if he comes to us and he's diabetic, and when we measure his blood pressure, it is equal to or above 130 by 80. Even then, we will start him on ACE inhibitors. He's hypertensive. He's not diabetic, no comorbidity, no underlying disease. His blood pressure is more than 135 by 80. or non-ambulatory blood pressure is more than 140/90. Okay, so if he's coming to us in the office setting and his blood pressure is more than 140/90, what will we do? We will monitor his blood pressure for another 24 hours. Okay, we will send him home and we will tell him that, okay, make a chart and record your blood pressure. And if the mean of that blood pressure reading is coming to be more than 130/80, then we label him as hypertensive. If the mean is not that, it is less, then it is white coat hypertension. Very simple. Just remember these. Above diabetic, 130/80, hypertensive. First time visit, more than 180/110, hypertensive. If first time visit, more than 140/90, monitor. And after monitoring, at least for 24 hours. It can be more than that also, but at least we have to monitor him for 24 hours. If still the mean is more than 130/90, 130/80, then he's hypertensive. If not, maybe he just has some anxiety when he comes to the doctor's office and his blood pressure rises. Okay, so this is how we check for hypertension. And if the patient is coming and he has hypertension, then what are the investigations we are going to do? We are going to start with basic investigations: electrolytes, creatinine, fasting glucose, hemoglobin A1C, lipid profile, 12-lead ECG, urine analysis, self-measurement of BP at home. Okay, it is recommended. Then if he is diabetic, then we have to do the urinary protein excretion. If the patient is coming to us with hypertension and he's giving us, we record his blood pressure monitoring, it is high, and he's giving us the history of episodic headache, palpitation, sweating. What is it? Pheochromocytoma. We have to do 24-hour urine for metanephrine. They might give you a history and they tell you that, okay, the patient is here for episodic headaches for the last 3 months. And along with that, he is experiencing some palpitations and sweating. On measurement in the office, his blood pressure is high. It is 160/110. So what is the next investigation we are going to do? We won't be doing this fasting glucose or creatinine. No, we will do 24-hour urine for metanephrine, because now we are suspecting pheochromocytoma. He's giving us the classic triad of this. So we have to do this. Next step, diagnostic step is going to be this. Similarly, if they tell us, give us a situation where the patient is coming to us and he's obese, and he tells us that I'm not able to sleep at night properly, or I wake up, I'm not able to breathe, and on a measurement, the blood pressure is high, then he might have obstructive sleep apnea, and we have to refer him from sleep studies. So depending upon the situation, what happens, our treatment, our investigations change. So the first line treatment will be, we will educate the patient about lifestyle modification, about their diet, about their regular exercise. If smoking, stop smoking. If alcohol, reduce it or quit it. Then maintain a healthy BMI with regular exercises. So what is the diet recommended for hypertensives? It is the DASH diet. Okay, it is an important question. So remember, what is the diet for hypertensive patient? It is DASH diet. Similarly, the salt intake should be less than 2000 mg per day. It is per day, okay? 2000 mg per day. And regular exercise, maintain their BMI between 18.5 to 24.9. And what are we starting them on? First line is always ACE inhibitors. We mostly start these patients on ACE inhibitors. If they are pregnant and they are hypertensive, then in pregnancy, it is contraindication. What are the contraindications of ACE inhibitors? It is pregnancy, ACE and ARBs, pregnancy and renal stenosis. So if the patient has any of these, we will not give them ACE inhibitors. In pregnancy, what will we give? We will give labetalol, hydralazine, methyl-dopa. Similarly, we don't combine ACE with an ARB, okay, and beta blocker with calcium channel blocker. If the patient is elderly, above 60 years, we do not give beta blockers to them as first line because of risk of hypotension. In African descent, in Black community, the first line is calcium channel blockers, okay, not ACE inhibitors. We don't give it to them. And yes. This is just the name of the medication. This is all what they have written. I've just extracted it out and I've explained it to you guys. Okay. Then similarly, lifestyle modification 3 to 6 months, and pharmacological, and then proper monitoring of the blood pressure for 2 consecutive visits every 3 to 6 months once the target BP is achieved. Okay, and once we are starting the patient on ACE inhibitors, we have to do baseline creatinine and kidney function test just to rule out any renal artery stenosis. So we will do the baseline, these creatinine, albumin creatinine ratio baseline test for ACE inhibitors. Okay. Let me just pause here.